Joe Philip Cancela Santos Raposo. I hope I have pronounced it right. I don't know.
Perfect.
Thank you. Graduated in medicine in 1988 by the Medicine Faculty of University of Lisbon and got his PhD in medicine and endocrinology in 2004 by the Nova Medical School of Nova University of Lisbon. He had his endocrinology residency in Portuguese Cancer Institute, being a consultant of endocrinology since 2006 at APDP, Diabetes Portugal. He's a member of Executive Committee of the DESD, Diabetes Education Study Group. Currently, he's an assistant professor of public health in Nova Medical School of Nova University of Lisbon. Over to you, sir. Just last week, I and Dr. N.K. Singh, we were involved in a meeting called as Coronocrinology. So I was just trying to patch up these two words, and I had organized a meeting, and it would be a good learning experience for us to hear what you get it from Lisbon. Thank you. Over to you.
Thank you, sir. Thank you to all of you. Greetings from Portugal, from an early morning on Sunday here, a sunny Sunday in December, which is good. And it's my pleasure to be with you, and having learned with you also. It's always good to share experience from all around the world. And I must say a very special word to Dr. Banchi Sabu, my dearest friend, who has still organizing all these things and putting all these things in place, which is, I realize it's a challenge. But so without further ado, let me share my screen. And here we go. Okay, so the topic was about two pandemics in collision, and we've heard by my previous speaker about diabetes and CVD, and now we also have diabetes and COVID-19. And today is a very special day also here in Portugal and in the European Union, since we have just started today the vaccination process for COVID-19. So what I propose to discuss, it's the possible links between diabetes and this new virus, and then speak a little bit about the COVID-19 pandemic with people with COVID-19 with diabetes and people with diabetes without COVID-19, which still needs our care, and how can we merge and take care of this process. So the question is what to do, what to adapt, and what to create. So this is not for sure new for anyone here in the audience, I hope. But I just want to compare how we deal with these two pandemics. So for many, many years, we, and at IDF, promote the IDF Atlas with these huge numbers of people with diabetes all around the world. And guess what? We are speaking about millions and millions of people all around the world. But up to this moment, we are really not frightened about this scenario. So for us, this is normal. And as I've heard in two talks before, it seems that we are all doomed to have diabetes, so nothing to take care about it because it's inevitable. But I really think that we must stress that it's possible to do different things, as it was demonstrated with COVID-19. So when we speak about the COVID-19, it's very similar. We showed the numbers, but that was still, and we are all afraid of COVID-19 for the right reasons, I hope, but still the numbers are very, very at a low rate compared to diabetes. And it kills less, hopefully, and luckily, than diabetes. But it's all around the world with a clear geographical distribution, considering the different waves of COVID-19. When we speak about diabetes, we speak about this growing prevalence of diabetes, and we are always speaking about how we fail with the projections for the next 10 years, 20 years, or 30 years, as is clearly demonstrated in this IDF Atlas here. And when we speak about COVID-19 cases worldwide, and this is quite recent data, we always speak about the growing evidence of the numbers with different geographical prevalence all around the world, the same as in diabetes, and the same about undiagnosed cases. And with diabetes, we know that diabetes, even if we say it goes to all people all around the world, it doesn't affect in the same way people all around the world. We know that the prevalence is still higher in high-income countries and similar to middle-income countries, lower or perhaps a little bit lower in low-income countries, but it affects different peoples in these countries. So it's really the social determinants in diabetes are really relevant, as are in COVID-19. And it is also clearly demonstrates by the IDF Atlas the different distribution between urban and rural areas all around the world. And as I've told you before, the number and proportion of adults with undiagnosed diabetes per different regions, we are always speaking about 30, 40, 50% of people with diabetes undiagnosed in different parts of the world. And guess what? And these are for the CDC estimates from February to September 2020. So even for people hospitalized, as you can see here, just 1 in 2.2% of the people hospitalized were reported, 1 in 6.7 of symptomatic illness were reported, and just 1 in 7.2 cases, infections were reported. And this means that even for COVID-19, which is a recent disease where all the people are aware of the importance of relating and reporting this disease, we are clearly underestimating the number of people affected. So as you can see, for the United States, it means that 91 million of people estimated total infection, 77 million had symptomatic illness, and 3.4 million estimated hospitalization, a higher, clearly higher number than the reported numbers. And again, the burden of the disease is measured just not by the number of people affected, but for the money that we spend on those persons. And clearly there are geographical and income disparities all around the world, as is clearly demonstrated for diabetes. And I just put it here from OECD, the possible burden for the COVID-19 representing a clearly higher risk than the 2008 financial crisis for the sustainable development of many countries in the world. And so if you can see here for the COVID-19, it really represents much less money in the systems, in the economic systems. And this is clearly a threat for the government, for economy, for finances all around the world. But while we take care of these in COVID-19, diabetes has been all around for decades, doing exactly the same, and we don't see the same perspective. So something that I like to talk when giving this kind of speeches, the perceived value of the disease. Diabetes is perceived as a normal, banal disease, while COVID-19 is a threat to all of us. But coming back now for this strange relation between diabetes and COVID-19, from the early report, and this is an early report from the Korean Diabetes Association, it was always possible to see that the prevalence of diabetes among people with coronavirus, COVID-19 patients, was about 10% in all cases of infection. And if you see the middle panel here, the diabetes prevalence among severe cases is much higher than among non-severe cases. And the same here, the diabetes prevalence among survivors of COVID-19 compared with non-survivors, it's clearly different. Diabetes is demonstrated here from an early beginning that it was clearly a risk factor for the serious forms of COVID-19. As you can see in the bottom panel, the mortality in diabetes is clearly higher than the mortality in non-diabetes in different series. And this was in Korea, but it's the same all around the world. And I just show you numbers from Portugal here, where at an early reporting here also in Portugal, where we had 20,000 cases of COVID-19, 5.3% were in people with diabetes, where people with diabetes were slightly no, considerably older, with a similar gender proportion, but the mortality, while the global mortality in COVID-19 was 2.5, in people with diabetes was 7.2. So 3 times more mortality in COVID with diabetes than with COVID without diabetes. And clearly, we know that it's not just the case for diabetes. And so this is also a report from China, where we have the diabetes clear, and we can see with the red line, diabetes was clearly a risk for poor outcomes during hospitalization. But even with people without diabetes, and we can see in the purple box in the bottom, getting to the hospital with a fasting blood glucose higher than normal represented an increased risk to poor outcomes during hospitalization of COVID-19. So clearly, high level of blood glucose is also a risk factor for poor outcomes. And this comes to the previous communication where we are always speaking about CVD risk in diabetes, but 10 years ago, we were also discussing CVD risk with pre-diabetes, because we always knew that a higher level of glucose, slightly higher than the normal, is already a risk factor for CVD. And we are just not taking care of that also. And so the other discussion was about, and here in Portugal at least, it was a huge discussion about if both types of diabetes were different, type 1 and type 2. And we know that both types of diabetes, and this is data from the UK, where they, as you can see on the right graph, age is clearly as a linear trend with the risk of mortality, in hospital mortality. But if you look at the bottom part of the graph, type 1 and type 2 diabetes are clearly also both of them risk factor. And to be honest, if we see here the difference, it seems that type 1 diabetes demonstrates a higher risk for mortality in hospital than type 2, but the numbers are quite different, as we know. So the conclusion of this paper was the result of this nationwide analysis in English, so that type 1 and type 2 diabetes are independently associated with a significant increased odds of in-hospital deaths with COVID-19. So why and what's the connection between COVID-19 in people with diabetes and these poor outcomes? Well, as I've tried to demonstrate, it's not a question of age. It's not just a question of diabetes per se. The glycemia is really important. And in this paper co-authored by Stefan Del Prato, early also, it was in July, the reason for these poor outcomes should be multifactorial, probably reflecting the syndromic nature of diabetes. So it's about age, of course, it's about sex, ethnicity, and comorbidities such as hypertension, cardiovascular disease, obesity, and probably it's this pro-inflammatory state and pro-coagulative state that we all know that exists in diabetes, especially in poorly controlled or not optimally controlled diabetes, that contribute to the risk of these worse outcomes. So it's tried to be demonstrated here, where we have the infection of these new virus contributes with probably with a direct effect on beta cells through or not through this cytokine storm. And so we'll have at admission hyperglycemia, this worsening metabolic control in patients with diabetes. And probably we have new onsets on diabetes, and we have a worldwide study now trying to report the new cases of diabetes in the sequence of the infection with SARS-CoV-2. But so and just to emphasize this, obesity, inflammation, coagulation, hyperglycemia, either connected with ketoacidosis or hyperglycemic hyperosmolar syndrome, the older age, the hypertension and cardiovascular disease, and the renal disease all contribute to this poor outcome in COVID-19, which is also represented here with, and I just put it here because there's also kind of discussion with the status of vitamin D, and as either social determinants or genetic determinants, we have some ethnic groups that also are reported to have a poorer outcomes of COVID-19 when getting to the hospital. And then we have also to try to understand if it's the drugs that we are using for diabetes contribute to better, poor, or indifferent outcomes during the COVID-19 infection. And as you can see in this table here, apart from the disadvantage that we recognize in many of the drugs that you are using in diabetes, so metformin with the risk of lactic acidosis, and SGLT2 inhibitors with the risk of hypovolemia, GLP-1 receptor agonists with the gastrointestinal side effects and aspiration, the sulfonylureas with the risk of hypoglycemia, the pioglitazone with the risk of fluid retention and heart failure, and the insulin with the risk of hypoglycemia. But there are advantages also in many of these classes, and the only one that, as you can see in this table, doesn't report any advantages are the sulfonylureas. And for people when getting to the hospital, we had interactions with the COVID-19 treatments, and as you can see here in the table, many of the drugs used here can interact with many of our antiviral drugs. But then, as I told you in the beginning, and getting to the end, I hope, and we also have to take care about people with diabetes and with no infection. And for that, this is a report from the ADA, and it's just to how to take care of the risks, management, and learning from other national disasters. So what we had to implement also here in Portugal, and I think in most of the countries all around the world, was how to promote the care of people with diabetes during this pandemic. And I think we all get to the same conclusions. We had to keep contact with the healthcare professionals through the use of telecare, even phone calls here in Portugal, face-to-face consultations for urgent podiatry and ophthalmology and many other situations. And we had increased a lot of the community and self-management of people with diabetes with their community and creating groups of support in local areas. As you can see, and it was also a point of the previous speaker in this communication, patient education is a key factor for diabetes care ever and ever. So keeping the clear point of contact for all patients, the reiteration of sick day rules, and repeat prescription for 28-day supplies or longer, and proactive review of patients. So patient involvement, patient empowerment, increasing the health literacy of patients is clearly the key point of success in diabetes care. So for this part here, just remember that people with diabetes are really the diabetes manager. So increasing their education, empowerment, capacitation, whatever you call, increasing their health literacy, keeping the system focused on people with diabetes needs, be proactive, and be sure to involve all the strengths in the community are really important. And just for a last word for vaccination, and this was the recommendation for the National Academy of Science in the United States, where they put people with type 2 diabetes at an increased risk of severe illness, so they should be in the first group of people getting the vaccine, and people with type 1 diabetes mellitus in the second group. As you can see here, the people with diabetes are in the phase 1B for vaccination, and this is not the same all around the world. I must tell you that in Portugal, people with diabetes with no other strong comorbidities are in group 2 of the vaccination. And just the last comment, diabetes like COVID-19, and this was published in the Lancet last month, diabetes is a wicked problem. And the wicked problem is those problems that we cannot solve just by scientific solutions. And we should take care as globally as possible, as was demonstrated by my previous colleague. So if you want to put in place a digital diabetes ecosystem, We should connect personal consumers, like food choices, physiological, sleep patterns, behavioral, like physical activity, psychological, the mood, environmental, hair quality, and genetical data with an understanding of social preference, like family meals versus eating alone. And these ecosystems should be integrated with our workload. So taking care of uh, our job as doctors, as clinicians, and still maintaining the empathy with the user. And for that, I reached the end. Thank you for being patient to hear me from Portugal. Stay safe. And for those in transition of the year, I wish you a happy 2021, better than this one for sure. Thank you.